used, it is kind of geared towards pharmacists, but you can still take the knowledge and apply it in all sorts of medical realms.
I mean, honestly, so much gold in this episode.
I mean, we struck it today. Struck oil.
What's going on, podcasting world? Welcome back for another episode of the Core Consults RX podcast. Saturday morning, getting our record on.
It's about as early as we get.
This is the earliest one we've ever done in the history of podcasts.
I think we did one at like 8 a.m.
Did
one
we?
time. I think it was before work or something like that. One time.
Maybe we did.
You might have been in like a coma at that moment.
I may have been. That's probably my best work.
You probably blacked it out.
It's probably my best work.
We got Pete back today.
Pete is back, and we actually let him sit at the table this time.
Yeah.
I'm at the big boy table this time.
Yeah, he fixed his hair, so we put him on camera.
Yep. So Pete's our producer, sound guy. He's been MIA building robots in Germany. But
yeah, spent some time in the Congo, and I'm back now too. So
well, just Germany.
can't promise I won't go back and disappear for 3 weeks again.
But so he's here sitting, hanging out with us. And for those of you who don't know, he's a engineer by trade. So pretty smart dude. So not medical, but also helps us a lot with the sound quality and whatnot. So figured we can have him at least throw his 2 cents in.
Yeah, it's nice to just sit in. So I'm excited.
So we had an idea to kind of throw out like kind of a big hodgepodge of MTM counseling points.
It's definitely hodgepodge, but it's quality stuff.
So, we kind of wanted to touch on a lot of different subjects all at once, but MTM is becoming a big focus, especially like in retail and community type pharmacy settings. Mm-hmm. So this one is going to be geared a little bit more towards the pharmacists, but
the I guess where it's used, it is kind of geared towards pharmacists, but you can still take the knowledge and apply it in all sorts of medical realms.
I mean, honestly, so much gold in this episode.
I mean, we struck it today. Struck oil.
Well, we'll see. We don't know what we're going to say.
Well, it's actually kind of funny because I was telling Mike when I was on his rotation, so this is probably June of 2017, we did a lot of MTMs, medication therapy management stuff. And so he was, giving me all these high quality recommendations and stuff to look out for. And so I was like, I got to write some of this stuff down. So I actually made a list, and at the top, I just put Mike's MTM tips. And so when he said we were doing this episode, I went and dug through my old binders and I found it. So I got it here with me.
It was right on his refrigerator.
He was sitting there right beside the wedding pictures.
I'd say in front of the wedding picture, but it's fine.
I'm going to get it laminated and framed.
You should.
Probably should.
Like I said, so much gold. Yeah. All right. So we will, how do you want to start? You want to start with the questions from Facebook?
Sure. We can start with the questions from Facebook, and we can talk about what MTMs are just really quickly and what they look like in different settings. So in the retail settings, MTMs might look like your boss is kind of saying, hey, you need to log on to this program, and these insurance companies are wanting you to do these CMRs or these comprehensive medication reviews. So you need to call these patients and talk to them for a few minutes. And some pharmacists are like, okay, no big deal. That's great. And some are kind of like, oh, what do I even talk to them about? It's not scary. It doesn't have to take an hour. It's actually probably shouldn't take too much more than 10 or 15 minutes max. And we're going to kind of show you our ways of approaching it and going about it in the retail setting. In a different setting, like in a clinic, this might involve an attending saying, hey, pharmacist, come in here and do a med rec with this patient, and let's see how we can, chop some things off or help optimize therapy. And so when you're just looking straight at a medication list with minimal information about the patient, this is where some of these tips kind of come in handy. Instead of looking at a bunch of drugs, you might see one and another together and say, okay, well, maybe we can take this off, or maybe we can do this lab or recommend this. And in a clinic, it's probably a lot easier to say, hey, this patient's not on a statin, doc, so let's put them on a statin. In the retail setting, it involves a little more like a phone call or something like that, and or at least telling the patient to have this conversation with the doctor. And so that's the two settings that we're looking at. But for those who aren't pharmacists and are dealing with medication management as well, these are still helpful things, I think.
Yeah, and I believe that with Marixa, which I guess was just bought out by Outcomes, so there's two main platforms that you could use for billing, Outcomes and Marixa, and now I think Outcomes bought out Marixa. But as of now, when Marixa was still kind of its separate thing, they would allow not just pharmacists to bill, but you could also bill as a a physician or I think an advanced practice nurse, and some other healthcare professionals were also allowed to bill. So it wasn't just pharmacists. But the big thing, like Cole said, I completely agree with, is that it doesn't have to take a long time. I think everyone has this mindset of like a CMR has to take 45 minutes. And it's just not the case, especially if you're not doing these face-to-face with a patient. Mm-hmm. So we have a lot of instances where you have to do them over the phone, and nobody wants to sit on the phone with someone they've never met for 45 minutes. It's not going to happen. But I feel like you can do, and we've done thousands of CMRs. You definitely can do a impactful, meaningful CMR in a matter of 10 or 15 minutes. You just have to really key in ahead of time on what you want to kind of go over with the patient.
Because you don't necessarily have to hit every single recommendation that you want to make. You might have to choose your top ones and start going through. And a lot of times the patient will kind of get tired and be like, okay, thank you very much. And they'll want to get off, which is, some people think that's intimidating, whatever. Don't worry about it. It's your job. If you do have an opportunity to have them face to face and have like a half-hour visit or something, then that's great. You're going to get to talk about a lot of things. But if it's over the phone and it has to be quick and dirty sometimes, then sometimes you just have to have. Usually I'll look at their list and I'll say, okay, what have they filled here? Sometimes, you're dealing with somebody who literally doesn't fill at your pharmacy. But if they have filled here, then you can see what's already on their file and what they filled frequently. And unless you have, questions about it, maybe you don't have to really go through that stuff as in depth. But if you can find some meds that Outcomes or Marixa has on there that they're not taking, and you can say, hey, are you still taking this? And they say, no, you just chop it off, and that's real easy. And then, that's just two minutes. And then the rest of it is spent trying to hit some of these counseling points or recommendations that they could bring to their provider.
Yeah, and I would definitely recommend, if you are going to be doing CMRs frequently, coming up with your own worksheet. We when Cole and I were doing these, we would basically have we made our own worksheet that we would fill out and just have several of them printed. And because we were also doing them for pharmacies that we were not actually in. So at one point we were covering about 80 different pharmacies for a particular chain. And so we were sending, obviously we're not in all those pharmacies, so we were sending the worksheet out to that pharmacy, and then the pharmacist, if we couldn't get them on the patient on the phone, the pharmacist at that site would then go over the CMR worksheet that we had filled out with the patient, answer everything, and we would bill it for them. So the CMR worksheet you can make however you want. There's some available on that other people have made online. We maybe should make our own and put it out there.
There you go.
We could do that.
Then have a little watermark at the bottom.
Yeah.
TM.
A huge watermark.
Core consult. Just right in the middle of it.
Right in the middle. It's super inconvenient.
It's a huge advertisement. Every time a pharmacy sends it away to another one, it's just big core consult.
No, we did this for you guys. It's definitely not for us.
It's not for us at all.
But
it's to help patients.
Yeah, that's what we're about. No, but we may throw something like that together and cool. Put that on the website. But so make your own CMR website. That definitely helps move things along. But so I guess we can get. We got a lot of different. We'll cover a bunch of different.
Yeah, we'll bounce back and forth.
Clinical pearls and disease states and whatnot. But I got some questions from the Medication Management Connect group on Facebook. Jessica, I appreciate you reposting this for us. But some of them asked questions, and so we're gonna go through some of those and make sure we touch on those subjects. But one of the first ones that came up was talking about Narcan and how to actually talk to patients about, getting their loved ones or themselves Narcan if they're on opioids. And I think this definitely, because of all the stigma around opioids and whatnot, definitely can be, I guess, an intimidating conversation until you kind of do it a few times. And this applies to not just patients that have Medicare or eligible for MTM, but this is really anybody who's taking opioids. And I know Cole has something to add to this too, but I think my personal kind of way of doing things is, one, I look at other comorbidities the person may have, like COPD, sleep apnea, things like that put them at risk for respiratory depression on top of taking an opioid. And then I just kind of listed as a statement from that angle instead of saying like, oh, you're on a really high dose of pain medicine, so you could overdose. People automatically get defensive. If you talk to them about it for the actual risk that it is because of other comorbidities and not put them in a light of saying like, oh, we think you're abusing your medication or anything like that, it becomes a lot easier to kind of discuss with them. Or, if they're willing to talk with them and their spouse, if you happen to see a couple, again, bringing it up in front, if the spouse is okay with sitting in on the conversation, giving them all the facts about the risks and be like, it's not just people who abuse medication. It's people with all kinds of different comorbidities can be at risk for it.
Yeah, and also people who have, the cocktail. So you'll see opioids and benzos together all the time. You'll see opioids and benzos along with muscle relaxers all the time. All of those are going to increase risk for CNS depression. I think that they even recommend they consider someone high risk of overdose, someone with a daily dose of over 15 morphine milligram equivalents a day, which most people have access, at least in pharmacies and doctors' offices, have access to PDMP or prescription drug monitoring programs where they can look that up, and a lot of times it calculates the MME score for you. And so that if you're just wondering, then, you see people in the 500s and stuff like that, and up to, I think 999 is the highest. So yeah, if it's over 50, especially upwards of 100 or more, then they could be considered high risk. COPD, alcohol use, all that kind of stuff. Or if they just ask for it. In South Carolina, we of course have a state protocol where the pharmacist can prescribe and give Narcan. And is that national now? Is that every state? I don't think it's every state.
I don't know if it's every state.
I don't think it's every state. But if you're in a state who can do that, then if they ask, then you can just give it to them. So those are the patients you're looking for. Sometimes you might be giving it to the patient. Sometimes you might be giving it to a caregiver or spouse or parent. Either way, someone other than them is going to have to be counseled on how to use the Narcan, because if they have overdosed, then they're not going to be using it on themselves. So you're telling somebody how to use it, but you would generally, if in the instance that they find you out, or find the patient out, you'd want to check for a response by yelling or shaking them. If they're not going to wake up, then you're obviously going to go ahead and call 911 and give the naloxone, even if you're not sure that they did definitely overdose. But of course, if you are sure, then you're going to go ahead and give them naloxone in one nostril, one spray. There are other dosage forms, but the one that we give out is the nasal spray. If there's not a reaction in about 2 to 3 minutes, if they don't wake up, then you can go ahead and give them the second dose. Generally, there are only 2 doses, and wait for EMS to come. You can start giving rescue breaths or chest compressions if you feel that that's warranted. And if they're not responding, and try to stay with them for at least 3 hours or until help arrives. But there's the Narcan nasal spray. There's a multi-step nasal spray, an IM injection, and an auto injector, which is Evzio. But yeah, I think that Narcan's the most common. And I'm pretty sure that you don't have to prime it because that wastes the spray.
Yeah, and a lot of times they use the injectable, like the pre-filled syringes, and just attach an atomizer to the tip of it to turn it into a nasal spray.
Yeah.
So that's the ones we always had when I was in retail. I think we have those at the clinic too.
Yeah, and it's definitely important to emphasize that you're not giving this to a parent or a spouse because you think that the patient is a druggie or they're abusing drugs, just like Mike said. It's just that these are dangerous medications, and this is something that's happening commonly. And with other comorbidities and medications, it's just important to have this safety net just in case.
Yeah, and if
they're elderly,
and if they do come in and they are, quote unquote, a druggie, you may have patients that have loved ones that do abuse drugs or IV drugs or whatever it may be. If you have someone that comes in on, that knows someone on heroin, I think that it's a good idea to definitely be very professional about that and still walk them through it and not give any sort of. I think it's easy for the stigma to kind of take over, and
right.
You got to keep it very professional, and those patients need to have help as well. And then obviously you could always recommend counseling or opioid use disorder treatment, things like that. But always making sure first and foremost the patient's taken care of. Medicine before personal feelings.
And there is the stigma out there that some people would be averse to the patient, especially if they abuse drugs, having Narcan because they think that might encourage them to abuse more. No. Some people feel that way. Either way, just be aware that you might run into that when you're recommending it.
Yeah, and that's not necessarily backed up by any sort of data.
It's not evidence-based, is it?
Yeah. All right, so hopefully that's some stuff on Narcan.
Yeah,
but
Narcan.
Somebody else asked about HIV meds and just some basic counseling points. That one's kind of hard just because there's so many different ones available.
Kind of depends, doesn't it?
I think the big one with that is to, before you even get on the phone with the patient, do a drug-drug interaction screen. Make sure that the infectious disease doc or whoever's prescribing the HIV meds is aware of whatever else their patient may be getting, and from other, like maybe the primary care doctor. And look for specific things. So like, let's say, if someone's still on like atripla, they may be, one of the components of atripla is efavirenz, which can cause, almost like psychosis type symptoms in some patients, really vivid nightmares, things like that. Addressing some very specific symptoms of a particular agent may be good. And then, just kind of looking for specifics like that. But I think drug-drug interactions is the big one.
Acid suppressing drugs frequently, even before you run a check, they interact with a lot of antiviral medications, including a lot of HIV medications and Hep C medications.
And Hep C is a big one, yeah.
So that's something to be aware of. And then, everybody knows, but just can't overemphasize the importance of adherence with HIV medications. And now that they have a lot of 1 pill once a day dosing, it is a lot easier than it used to be, but still good to emphasize.
Absolutely.
But as far as a telephone CMR goes or something like that, not too much more, you would say, unless there's something specific with a specific medication.
Yeah, it's more going to be dealt with, in clinic based on their viral load, CD4 count.
Yeah.
So there's not a whole lot you would probably need to address, but drug-drug interactions would be the big thing.
I don't really think I don't really think we would talk much about infections and looking out for that stuff. I feel like that'd be more their HIV provider.
Yeah, I think with something that specific, hopefully their HIV. I mean, you can always bring it up, talking about opportunistic infections, ask them if they know what their CD4 count is, but usually they're going to be under the care of an infectious disease doc who would have all that covered with something, specific like HIV.
Or just say, do you have any specific questions about your HIV medications or your HIV in general?
Absolutely. Or finding them maybe some additional coverage if they don't have like Ryan White funding or whatever the case may be, if they're actually going through their insurance, especially for commercial insurance. There's a lot of all the main treatment options now, are a lot of them are available through Gilead. Gilead has great financial assistance programs set up. So, maybe helping them with the cost if that's becoming a burden. So
absolutely.
The next one is asking about how to address the lack of statin use in patients with diabetes. She said that she has doctors who refuse to add a statin, saying my patient's cholesterol is too low as is.
So this one's kind of fun. This one's interesting because what else does statin use in diabetes affect? It affects your 5-star rating. So there's a lot of pressure on retail pharmacies to get their patients on statins and get them adherent to statins because that affects their reimbursements from Medicare and Medicaid. But there's not always a whole lot we can do about it except for, contact their doctor's office. And most of the time you would probably just leave a voicemail or fax them or something like that. But there are some persuasive techniques you can use if the doctor feels a certain way, like their LDL is too low, right?
Yeah, I think, first and foremost, like we have data back. There's a reason why the insurance companies want the patient with diabetes on a statin, even if they don't have cholesterol issues. So, the CARDS trial is the first one that kind of comes to mind, and that was primary prevention in patients with diabetes. They added in atorvastatin 10 milligrams and, showed that it improved outcomes, cardiovascular events. And so, there's primary prevention data available in that patient population specifically, so that's part of it. But there's also a lot more data that's come out recently, like with the PCSK9 inhibitors. We have like the FOURIER trial that has showed, this improved cardiovascular outcomes with adding a PCSK9 inhibitor to patients who are already taking a statin. And in those patients, the baseline LDL was around like 90, 92, somewhere around there. So, it's one of those things that it's, what is too low for your LDL?
So that was the baseline, and they got it down to an average of about 30. and they didn't see an increased risk of new onset diabetes or neurocognitive events, which is what I think people get concerned about. But they did see a significant difference as far as the risk of cardiovascular events. So yeah, as far as we can tell, there isn't a too low. They've looked at pravastatin in elderly patients and getting their LDL low, and they haven't seen any increased risk. They did MME scores and didn't see any increased risk there. So you can let them know that diabetes in general puts them at a significantly higher risk of cardiovascular events. The statin is going to decrease it, and at this point, we haven't seen anything that's too low. The new lipid guidelines, which we did a podcast on, are recommending in patients with diabetes having an LDL less than 70. In general population, it's usually recommended less than 100, and this is in the last few years since we didn't really have specific goals, and now they have like the extreme risk category. Well, they'll recommend less than like 55. So there are guidelines that are recommending really low levels, and we're not seeing any particular issues there. So I think you can make the recommendations, and if they're asking for a specific drug, we would usually prefer the high risk medication. The high intensity medications like atorvastatin, rosuvastatin. We don't really prefer simvastatin, and I've got, there's a couple of trials that support that, but yeah.
Yeah, especially if, they've had some sort of event on top of diabetes. We have data showing that atorva 80 is better than Prava 40.
TNT. That's different.
Yeah, Professor Progress. Geez.
I think it's Progress.
Progress. No, Profess, because I think Progress is, look it up real quick so we say that correctly. Geez, I can't believe I just had a... This is what happened Saturday morning. TNT was 10 versus 80.
TNT was 10 versus 80 in stable coronary. Yeah.
Prava versus atorva. You see this? This is how we improvise in real time.
Profess was aspirin dipridamole versus clopidogrel in preventing stroke.
It's because it's like the Timmy 22 is the other part of it.
Well, either way, there's a trial out there that shows it. We'll find it eventually.
That makes me so mad.
Can't get them all in mind.
Prove it. Jeez. Progress is indapamide versus prandipril.
It had a P in there.
Yeah, it did. Okay, sorry guys. Prove it. Timmy 22 is the Prava versus atorva. I knew it was a real trial. But there's definitely a lot of data proving that statins can help us, especially if they've had some sort of event. So I think that, and that's a hard one too, because if you're not in the clinic with a doctor, convincing someone that you've never met before that they should prescribe a new drug.
Being in the clinic is much easier, but if you're calling them from some big chain pharmacy and saying, hey, you need to prescribe this, even though you don't want to, it's not always well received. So there's only so much you can do, but there is data to support it. And
bringing up the star ratings too, I think is a good, showing them that it could actually affect them financially too, based on the data. It may get them thinking. They may not respond to it the first one, but may at least get them thinking about it. And you can always at least start the claim and leave it in there. And if the patient gets started on the statin, then bill it. Bill that and the other thing too would be talking to the patient specifically. Get the patient excited about it.
Give them you can, and they'll say, well, I don't have high cholesterol, and then that's a good opportunity to say, well, it's not necessarily about that. It's about risk, and bring out the old ASCVD risk calculator and let's plug in statin versus non-statin and see what their risk is.
Yeah, for sure.
And they might bring it up to the doctor themselves.
Absolutely. So hope that helps a little bit. The other one was duration of dual antiplatelet therapy beyond 1 year. So that's a loaded question. That's basically the guidelines now are looking at patients making it patient specific because there's so many other factors you have to kind of weigh into the decision of whether or not to continue dual antiplatelet therapy. They do recommend the newest guidelines from 2017 and basically recommend that you should be looking at this from a patient-specific standpoint and assessing bleed risk along with their history and what other kind of conditions, comorbidities they may also have. So if you are curious about it, there's an app that you can download that was actually made by the American College of Cardiology. It is called the DAPT Risk Calculator, and it's like a light blue with a white and blue pill on the front of it. And actually, now that I'm looking at it, it kind of looks like the capsule with the pill in front of it. It kind of looks like our logo.
Did we rip them off?
Minus the, no, this is made after us.
They ripped us off.
Jerks at the
We're just doing that all the
College
time.
of Cardiology. Yeah, they are. But there's a calculator you can download. It's free. You put in the patient's age, and then it'll have you select all that apply as far as our comorbidities. So they have diabetes, cigarette smoking within the last 2 years, a prior myocardial infarction or PCI, history of congestive heart failure or left ventricular ejection fraction less than 30%, hypertension, renal insufficiency, peripheral arterial disease. So if the patient has any of those, you click those boxes, and then you would also click that when, as far as the procedure goes, were they actually having AMI at presentation, or was this like a scheduled thing? What kind of stent diameter, stenting of vein of graft. There's other things you can apply there, and then it'll give you basically a risk of whether or not they should continue, or what the risk of having a bleed or ischemic event would be if they continue this therapy.
So similar to Has Bled with AFib, it's just a guide. It's just to give you, a relative reference. And this might be more handy in a clinic setting. So if you're in a retail setting and say you're looking over a medication list and you see two antiplatelet therapies, and you're like, is this patient supposed to be on this? Maybe you look back at their history and it's been more than a year. Is there too much that you can do because you don't know their history, you don't know when they had a stent placed or whatever they had. But you can check and see, okay, is this the same doctor who's prescribing this? If so, then hopefully it's a cardiologist, or it's just a primary care doc continuing therapy and they know what they're doing. If it's two separate docs, then maybe mention it to the patient and say, do they know that your different doctors know you're on both of these? And maybe they say, well, last time I was in there, they didn't ask for my medication list, so I don't know. And they can just bring it up with their doctor, and maybe they take them off of one if they don't need it.
Yeah, especially if they're taking aspirin on their own.
Right, yeah,
definitely
if they're doing it OTC.
They hear it's helpful for their heart, and they start taking it.
They're already on Plavix for something else.
Yeah. So that's definitely going to be patient specific, but I would encourage you to download that app and kind of look through it. And then the 2017 it was basically a summary of the European Society of Cardiology guidelines that the American College of Cardiology republished, and so it's available, so you can check that out for free. But they have like a list of their 10 summary points. So that's all the direct questions, I think, from Facebook.
Cool.
I hope I'm not missing any, but I guess let's talk, since diabetes, at least in our neck of the woods, diabetes is very, very prevalent. Mm-hmm. So we'll talk a little bit about...
Gotta love the South.
Yeah, let's talk about some diabetes. The first thing I always start off with patients with diabetes is, looking at their regimen, obviously, but then, I always start off the conversation with asking them what their A1C is. That based on their response to that is how I kind of continue. Because you have patients that are like, oh, it's a 6.8, and they know exactly what that means. Their diabetes is super controlled, and they're good. You can reinforce diet and lifestyle and things like that, but I wouldn't spend a ton of time on the different medications and stuff, other than maybe metformin. If they're on metformin, I would ask them about any kind of like neuropathy symptoms, because the metformin can deplete your B12 levels, or basically metformin depletes your intrinsic factor, which in the gut, so you're not able to absorb B12. And so these patients may start developing some signs of neuropathy, and it may just be B12 induced. And so they can take a B12 over the counter, whether it's even sublingual oral or shot if they have a prescription, and kind of get those levels back up, and the symptoms may go away.
And a lot of these patients are overweight and have GERD, and so they might be on PPIs. So it makes PPI with metformin, you're getting even less absorption of B12. So if they come complaining of neuropathy, and maybe they're on gabapentin, say, hey, why don't we try B12, and maybe you get off that gabapentin.
Yep. And the other thing too would be if the patient gives you kind of a a different response with the A1C, basically saying you can tell they don't understand what that means, or, it's really uncontrolled. I always ask them, has anyone ever explained to you what A1C is? We always throw that term around, but to someone who's not in the medical field, A1C doesn't necessarily mean anything. And so I always make sure that they've...
Yeah, Pete, does that mean anything?
It doesn't mean nothing to me.
Good. We're about to find out what it means.
So, just something that's very simple. I always just, explain to them that it's a 3-month snapshot that's looking at all your blood sugar averages over that course of time. That way you don't have to stick yourself 24 times a day and then average those over 3 months. This gives us a big picture look as far as how your blood sugar is doing overall. And you'd be very surprised at how many people have never had that explained to them. And you can, for those of you who are doing CMRs, things like that in person, you can get free handouts to give to people that explain A1C and things like that from novomedlink.com. It's a company from called Novomed, or from Novo Nordisk.
Novo Nordisk.
It's their healthcare professional website.
And that's what I do with my diabetes education, and they're great.
Yeah. We use them in the clinic too. And
they'll send you boxes of free stuff.
Yeah, they will.
It's pretty awesome.
You just tell them your healthcare professional will send you whatever you want.
It's like Amazon for free.
It's great. But the A1C is where I start. And then from there, I kind of go into the medications. So the big one I would keep an eye out for is looking for patients, especially the Medicare patients, if they are on sulfonylureas. Mm-hmm. With the current guidelines, we typically save sulfonylureas for patients who can't afford other medications. Mm-hmm. If they have Medicare Part D and you're doing a CMR on that patient, they most likely can get a different medication that is going to provide much better outcomes.
Especially if they're not on metformin.
Right.
Let's switch those things up.
So, I'm a big fan of trying to find something instead of the sulfonylurea. Those are like 5th line now.
And as long as they're on it, just make sure that you recommend that they take it with food because they're so high risk for hypoglycemia. And your star rating is also affected by how many high risk meds you have in elderly patients. Are those considered high risk medications, or is it more like Ambien and
I think sulfonylureas are something that
I think it's anything
are considered like suboptimal.
I think it's like anything on the beers, and I think those might be there. So if you can switch it up to something better, then there you go. Helps you too.
And you can always do. We've mentioned this app a few times, but it's called Formulary, and you can run basically like a test claim on against the patient's specific insurance, including different Medicare plans, and see whether or not the medication is covered, or see whether it needs a PA or whatever the case may be. And so, and if you have a person that basically doesn't want to do an injectable, and I see this almost every day, they refuse an injectable. One thing I do is I actually carry a pen needle around with me when I'm seeing patients, and I actually open it up and show them how small the needle is. And I think that a lot of patients said no from like family members or grandparents or whatever that may have had diabetes. They remember the needles being a much different thing. So showing them how much better the technology is now can definitely help. And or explaining the once weekly options for GLP-1s. Usually the insurance companies will cover either Trulicity or Ozempic, one of the two. Stay away from Bydureon; it's garbage. And I think that's another good option for patients. And then especially if their A1C is not controlled.
Yeah, I've seen it in patient charts where it's like, star, 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 patient refuses injection, star, star, star. And I mean, you can, from what I've seen, at least 50% of the time, you can talk them into an injection, and it's no big deal. And probably 75% or more, you can talk them into an injection. But if you see on their profile they don't have metformin, and maybe they have insulin on, or they have something else, then you can say, hey, have you ever tried metformin? You might get no, you might get yes, had really bad diarrhea. You say, well, hey, did they try extended release? Were you taking it with a big meal? Did they try cutting back your dose and titrating slowly? There's a lot of stuff you can do, and potentially recommend to the doctor, potentially have the patient readdress it, because metformin is a great first line option, no matter what you're on.
Absolutely. But so just kind of looking at the big picture outcomes for diabetes is the thing I would focus on.
Other little things like, the hypoglycemia, counseling on that. If they have a beta blocker on, you can counsel on it blocking the signs and symptoms of hypoglycemia, except for sweating, because it's going to keep your heart rate down. So, if you notice that the patient is sweating and they might be feeling funny otherwise, maybe check your blood sugar, see if it's under 70, and treat per that.
Yeah, there's a lot of good handouts you can give patients on that as well to just so they know how to treat this, look for the signs and symptoms and also treat hypoglycemia.
If they're on a statin, you can recommend taking it at night. If they're not, get better results that way. Stuff like that.
Yeah. There's, as far as blood pressure meds, obviously assessing whether or not, especially patients that are on multiple blood pressure meds, assessing whether they're on appropriate therapy is definitely good. Looking for little things like, let's say they're on amlodipine and lisinopril, then, asking them how they take it currently, and then maybe suggesting to take the amlodipine in the morning, lisinopril at night. Lisinopril, at night, we have data like with HOPE and MicroHOPE showing, the outcomes from an ACE inhibitor, and they were also dosed, the ramipril in that study was dosed at night. MAPEC, if a patient's on multiple medications, has shown that switching one of those to nighttime can improve outcomes, basically because you don't know if the person is considered a dipper, like a normal circadian rhythm, or a non-dipper, and so you kind of cover all your bases that way. And the amlodipine is going to have a long half-life, like 30 to 50 hours, so you can treat that in the morning. It's going to cover them all day, and the lisinopril will cover them at night if they do drop. Splitting the dose of lisinopril is always
maybe
an
doing
option.
It twice a day is kind of a more recent recommendation that people have been doing.
20 milligrams twice a day versus 40 once a day can lower blood pressure a little bit more. We don't know that it improves outcomes necessarily, but it does lower blood pressure, so we think it may improve outcomes.
Might keep off one extra med that you might not need.
Yeah. And then thiazide diuretic, one of the new things with the guidelines is if a patient is on CCB, ACE, or ARB, and then a thiazide diuretic, and they're still not controlled, one of the first things to do is, because most likely they're on hydrochlorothiazide, switch to either chlorthalidone or indapamide, because those are the evidence-based thiazide diuretics, and they do give better blood pressure lowering as well.
I've been seeing more indapamide the last few weeks.
Have you?
Yeah.
Good.
It's good.
Good.
Yeah, we had to order it, didn't have it in stock.
Unbelievable.
But, prescriptions for it.
And indapamide, I think, is on some of the the $4 list and things like that. It's pretty cheap now.
Yeah, it's not too bad.
And then the fourth line agent, if you do need one, kind of keeping in mind, you'll see a lot of places that'll just prescribe beta blockers at that point. Mm-hmm. We have a study called Pathway 2, and we've probably talked about this a couple times in the podcast, but basically, they've took the patients who needed a fourth line agent, gave them either spironolactone, doxazosin, or a bisoprolol, and showed that the spironolactone was significantly better than the other two options. So before you start alpha blockers and beta blockers, probably better to do the aldosterone antagonist.
And especially if they have diabetes and, if they don't have an indication for a beta blocker, if you can get that off, then, lower risk hypoglycemia.
Yeah.
Especially if they're on insulin, because hypoglycemia is what kills people. Hyper doesn't necessarily acutely. So
not acutely.
Just over time.
And especially with watch for carvedilol and labetalol. Also, the alpha beta blockers. Those are the ones that are really going to be bad as far as covering up signs and symptoms. Mm-hmm. Just make sure you definitely go over having a meter with them and make sure patients are taking precautions.
Ask them if they're monitoring at home. And if not, recommend a monitor. Recommend what you have in the pharmacy, because the newer guidelines are saying, we want to monitor in the doctor's office, but make sure they're monitoring at home because white coat hypertension is a thing. And, if it's too high in the office and they're treating that, might be going low at home.
Yep. What else? We could do...
Blood pressure-wise. Heart failure stuff, so that's pretty common. If you see patients on heart failure medication, especially if they're on Lasix, talk to them about their daily weights. If they have more than a 3-pound weight gain in 24 hours-ish or more than a 5-pound weight gain in a week, recommend contacting their doctor. Or if they have, sometimes the cardiologists have other recommendations based on, if they might say 5 pounds in 24 hours or whatever, just if they have other instructions. But if not, that's pretty general.
Yeah. Also, checking, a lot of these disease states, you'll also see depression as a very common thing. And if you see any sort of indication for depression, if they're on even just one medication, if it's low dose, giving them a copy of one of the rating scales. So I always use PHQ-9 or even PHQ-2.
Yeah, you can do that over the phone.
Yeah, exactly. giving them a copy of it, even if they're on, especially if they're seeing a primary care doc, give them a copy of PHQ-9, tell them to fill it out, and whenever they have some free time, and bring it with them to their next appointment. It may, help the doc out by hopefully they've gotten a baseline established, and then kind of see whether or not they need to switch the medication or augment based on the patient's signs and symptoms of depression.
Yeah. Or even, how's your mood been lately? Yeah. Sometimes you can just tell by their initial answer whether you should follow up on it, or sometimes they're like, oh, I'm great. I don't let this get me down, blah, blah, blah. I have these, and these. And, that's good.
Yeah. COPD is another one you probably see that, there's not a whole lot you can do other than just having them check to see how often they're using their rescue inhaler, see how many exacerbations they maybe have had, making sure they're taking their medication as directed. But the other thing you can do is you can give them the questionnaires to take with them to their pulmonologist or whoever's treating their COPD. You can give them things like the COPD assessment test, the CAT, and have them fill that out again and kind of take it with them. And that kind of can provide some insight onto which, whether they need to switch medication or add on another agent.
Yeah, I think one of the biggest things, like you said, is how often are they using their rescue, and do they understand the difference between the controller and the rescue? If you see that they're filling their Pro Air every month, but they're not adherent to their Anoro or whatever it is, then say, you're supposed to be using this every day, and you only save the Pro Air for when you need it. And if you're needing it this often, then you might need to talk to your doctor about stepping up therapy.
Yeah. And if they aren't taking their controller of Y, if it's a Noro, let's say that they're on, maybe that's the one that's not controlled or not covered rather under their insurance. So, finding them an alternative. So, looking for one of the other LABA LAMA combos and seeing if you can switch it to, the
Advair is generic now.
Advair is generic now. And if let's say the patient is needing to step up therapy and you want to make a recommendation and they're going to their pulmonologist for an upcoming appointment, let's say they're on something like tiotropium by itself, you've kind of fill out their CAT score and you realize that they would be a candidate for stepping up in therapy. We know that patients, especially if they've had an exacerbation, would do better with a LABA-LAMA combo than a LABA-ICS. And if they're already on something like tiotropium, you could look at just adding on olodaterol, which comes as a combo product. Was it Straverity? I think is the brand name for that. You can, do that, and that's that step up instead of switching to something like Brio or Advair or something has actually been shown to give some improvement in COPD patients. So
and some of this sounds kind of involved with, filling out CAT scores and blah, blah, blah. But a lot of this, you're going to look at their med list. You're going to identify one or two of these things that you can bring up and then make that your focus and see if you can hit a couple of those things during the 10 or 15 minutes. And if you can, great. If you can do more, great. And if not, you just do what you can.
Yeah. If it seems too involved, then just please stop complaining.
Yeah, just don't complain.
You guys asked for this.
Yeah. But we're going over
everything.
all of it. So you're not getting, there might be one patient that needs all of this counseling, and then you might need more in 10 or 15 minutes. But for the most part, it's just a couple things.
Yeah. But, maybe if you have an anemic patient that's, taking iron, making sure they're, taking the right amount, making sure they're getting follow-up appointments to have lab work done, making sure that if you have a patient that needs calcium, if they're on things like PPIs, because you need an acidic environment to absorb calcium, making sure you having them switch to calcium citrate instead of calcium carbonate, because that calcium citrate will still be absorbed even if they're taking a PPI or H2 blocker. So, things like that just really simple, quick fixes that you can make and identify and just kind of have these things in the back of your mind so that, and it takes practice and, you kind of keeping up with information and reviewing and looking through more information and continuing to learn yourself so that these kind of are just ready to go in the back of your head when whenever you're looking through a chart. I mean, these things should be kind of popping out at you right away before you even ask the patient, and then right where to go. So the more your knowledge kind of gets centered, then the easier these CMRs become. And
speaking of how to take medication, so PPIs, we've talked about in other podcasts, but you might see patients with a PPI twice a day. more than likely that's probably not necessary. They are probably just not taking it like they should. Sometimes you'll see in the directions, take 30 minutes before breakfast or take 30 minutes before a meal. That's fine. You could say take 30 minutes before a significant meal. That's okay too. But really they should be taking it 30 minutes to an hour before the biggest meal of the day. The proton pump inhibitors are inhibiting the proton pumps, the acid secreting pumps on the parietal cells. When a patient eats, parietal cells express those. So the more they eat, the more that are expressed and the more the proton pump inhibitors are able to block. So it's going to be more effective, especially early on if it's before a bigger meal and if they're getting control that way, because PPIs can essentially create complete cessation of those acid secreting pumps. So there's issues that go along with that long term and that sort of thing. Refer to our GERD podcast for that. But as far as, just a nice quick counseling point you can give somebody, I think that's pretty helpful.
Yeah, absolutely. And it's really surprising how many people take their PPIs wrong.
Yeah, most.
And if you have someone that literally cannot take it appropriately, they just, whether or not it's a work schedule thing or whatever it may be, switch them to Dexalon.
Yeah.
So that's that way. Dexalon doesn't have an indicator, or doesn't have a need to be taken 30 minutes to an hour before a meal. So kind of absorb and shut those proton pump inhibitors or proton pumps off regardless of the food or not. So.
And other dosing recommendations, we've got thyroid medications all over the place. So levothyroxine, usually 30 minutes before anything else. In the morning is best on an empty stomach. And hopefully, whether they're taking it right or not, especially if they've been on it for a while, their dose has probably been adjusted for that, but still taking it appropriately for the long term is better. But then bisphosphonate dosing as well, depending on the one, sitting up and drinking as much as they need to drink and all that kind of stuff for whichever one they're on, is a good recommendation just to make sure they're getting as much as they can out of their bisphosphonate.
Yep. Always checking herbals.
Yep, always asking about OTC and herbals, man.
Lots of drug interactions. I think we've talked about those in the podcast before too. If not,
we talk about everything.
There's posts on Instagram you can check out. But using LexiComp or Natural Medicines database to kind of evaluate drug interactions if the person is taking an herbal, always important.
Other OTCs, NSAIDs, have they had a heart attack? Do they have diabetes? Do they have kidney failure? Let's get that ibuprofen off. If your liver's okay, then try Tylenol. And Tylenol doesn't work for me. Well,
switch to naproxen.
Right. Do something different. And other OTC stuff. So they might be using a PPI and they're on an antiviral and their HIV doctor doesn't know that they are taking over-the-counter PPI, stuff like that. Or interactions with maybe a multivitamin and a thyroid medication or other little things like that. You'll catch it when you ask them.
Yeah, but, they start an antibiotic, they're on Doxy or levofloxacin or something, multivalent cation interactions. So the antibiotics don't get absorbed. Yep. Things like that.
What else? If you see a patient who's on a nitrate who has filled a PDE5 in the past, Cialis or Viagra, hopefully somebody's told them already, but
just high five them and tell them to
just keep up the good work. No, so never take them together. Ideally, not within the same day, but at least 12 hours apart. I think it's like minimum. So I would just.
I think it depends on the PDE5
too. Yeah, it depends. So I would just emphasize that just don't even take those anywhere close together.
Yeah. What else we got?
Simvastatin.
We're just ad-libbing right now.
It's all the just little counseling points that come up. Simvastatin and amlodipine together. A lot of times your computer system might catch this one, but if it's 20 milligrams or less of simvastatin, it's generally okay. And I think, of course, less than 10 milligrams of amlodipine. The reason for that is we're not really recommending 80 milligrams of simvastatin anymore per search trial. More adverse events, similar outcomes or no better outcomes. Yeah. If the patient has been on simvastatin for 12 months, simvastatin 80 for 12 months, FDA says it's okay to leave them on simvastatin 80, but we really wouldn't want amlodipine on with that. It's a 3/4 inhibitor, 3/4 chews up simvastatin. And if you're inhibiting it, then just going to get high levels.
Area under the curve greatly increases.
Yep. High risk for myopathies, rhabdo, that kind of thing.
Yeah.
So.
All of a sudden, 20 or 40 milligrams turns into a lot more than we thought.
More. So that's why 20 is pretty much the maximum. Yeah. And maybe it turns into 40, but okay.
Yeah. So, or just switch them to a better statin and call it a day.
Yes, or just get them off of that and go to Atorva or Rasuva, which doesn't have that interaction as significantly.
Cool. Anything else we got you can think of?
Mucinex dosing.
Yeah, and this is kind of all over the place, but one of the ones that I've seen a lot is because the guaifenesin, you see 100 milligrams of guaifenesin, you're just not doing much. I've seen some different studies looking at different doses, but one that I kind of think about is I've heard 2,400 milligrams seems to be effective. So if you're using the extended release like Mucinex version guaifenesin, it comes as a 1,200 milligram tablet that's every 12 hours, which gets you to your 2,400 milligram dose. Or there's also the immediate release guaifenesin tablets that are like available as 400 milligrams, and you can do 2 of those every 8 hours and get to that dose. I've seen some small studies that have looked at less dosing than that, but yeah, definitely 100 milligrams of Robitussin is not doing it for you.
No,
it's a waste of
placebo,
waste of time. Cool. Well.
So do you guys feel like you got some good information?
So after all that, hopefully the CMRs get a little easier for you.
Just look for a couple of those things, and Mike's trying the sound effects, but I guess they're not working today. But yeah, just go through the medication list super quick. You're going to have 400 million things going on if you're a retail pharmacist at the same time, but just look over real quick, check their meds with them for 2 minutes, and take another 5 or 10 and try to hit a couple of counseling points if you're able to, and then bang, you just got yourself. If you can hit a couple of these and change some sort of behavior and emphasize something that's important, I feel like that's a successful CMR. And they might get another one next year, and you're able to hit something else. And maybe the patient knows all these things, and they didn't need it anyway. And great, that patient's good to go. But that doesn't happen all that often.
And if nothing else, if you don't see any other value at this, I will say, and I've preached this 100 times, retail pharmacy is changing and it will not be there forever. And so this is a good opportunity to get yourself practice in more of a clinical role, kind of going through these things, doing CMRs very quickly, identifying these different trends. And so, if nothing else, know that it's beneficial for you as a healthcare professional and in your growth in your career eventually down the road.
Yes.
So nothing time wasting about it. It's definitely important, and you can learn a lot from the more you kind of keep diving into this material.
Yep, I agree.
But so thanks for the questions from the Facebook group, and we'll hope you guys found this somewhat valuable. But thank you all for listening. If you do like the podcast, definitely leave us a comment or rating, subscribe. It helps us out greatly. If you have any questions, the emails will be in the show notes, and then also reach out to us on any of the social media platforms at CoreConsultRx, and we will get back to you as quick as we can. Thank you guys so much for listening, and we will catch you next time. See ya.